Welcome. What were the medical firsts in the Steel City of Sheffield over the last 200 years? We set out to find these in the Overend-Knight series of medical history podcasts, named after two of the founding figures of medical education in Sheffield in the 1800s. As the University of Sheffield Medical School approaches its bicentenary in 2028, each episode in the series will feature medical discoveries discussed by scientists, medical experts and medical historians. Listen to find out about the personalities involved, life in Sheffield over the past 2 centuries, scientific research discoveries, and where some of the medical treatments we take for granted today actually came from.
Hello, you're listening to another edition of the Overend-Knight podcast. This series is named after the surgeon Hall Overend and the physician Sir Arnold Knight, who were leaders in the 2 rival medical schools in Sheffield in the early 1800s. I'm Alan Pacey, scientist, broadcaster and academic, and in these podcasts we celebrate medical discoveries in Sheffield. In this episode we're going to turn to an area of cardiovascular disease where Sheffield doctors and scientists have made key contributions, and that's in the area of pulmonary hypertension. Joining me are 2 doctors from Sheffield who treat heart and circulatory diseases, but also have an interest in the history of medicine. So a very warm welcome to Abdul Hamid, consultant cardiologist from the Sheffield Pulmonary Vascular Diseases Unit, and also as he's an honorary senior lecturer at the University of Sheffield. And also welcome to Will Parker, clinical lecturer and registrar in cardiology at the University of Sheffield. So Abdul, let's get straight down to business and our topic for today, pulmonary hypertension. Now I recognise both of those words, pulmonary to do with the lungs and hypertension, high blood pressure, but I don't understand both of them together. So can you begin by telling us what pulmonary hypertension is?
Yeah, pulmonary hypertension is increased blood pressure within the lung circulation. Now the human body has 2 principal circulations, and blood is pumped by the left side of the heart through a series of tubes called arteries to every organ within the body, or brain, kidney and liver, for example. And this blood then has to return back through another series of tubes called veins to the right side of the heart. Now the right side of the heart has a much easier job. It just has to send the blood to the lungs. And it can do this with a lot of ease without any problems. And it sends this blood to pick up the oxygen and to remove the carbon dioxide. This blood is then returned back to the left side of the heart and the cycle repeats itself. This latter circulation is called the pulmonary circulation, and it sits between the left and the right side of the heart. The whole system operates at a pressure, but the systemic circulation is much higher than the pulmonary circulation, which is around a fifth lower. Now when people talk about having high blood pressure, they almost always refer to the blood pressure that's measured on your arm. And that, however, refers to the systemic circulation. What's less common though, but often underappreciated, is that pressure within the lung circulation can also be high. And this is called pulmonary hypertension. Pulmonary hypertension has a wide range of effects, including reducing the ability of the lungs to oxygenate the blood, unable to increase blood flow through the lungs when one exerts themselves, and this can cause breathlessness. But when it persists for a sufficient duration, and depending on the severity, this will put a lot of strain on the right side of the heart. Long-term strain on the right side of the heart can lead to right heart failure, and this usually involves fluid retention in the legs. When pulmonary hypertension does develop, it's a major contributor to illness and your survival.
So I'm familiar with, going to see my GP or going to see the practice nurse, and she checks my blood pressure by putting the cuff on the arm, and it kind of the machine makes a noise, it expands, and they take a reading from that. But Abdul, from what you're saying, that isn't going to give the whole picture, and it certainly isn't going to measure pulmonary hypertension.
Unfortunately, the cuff on the arm doesn't really give us any meaningful information about the blood pressure in the lung circulation. Modern investigations such as medical ultrasound of the heart, a CT or an MRI scan can give very helpful clues to suggest the presence of pulmonary hypertension. However, an accurate and precise diagnosis requires one to directly measure the pressure, and we do that through right heart catheterization.
So, Will, I know that things like eating lots of salt or putting on weight can cause hypertension as I understand it. But what are the causes of pulmonary hypertension?
There are a number of possible causes, and we often classify these into 5 main categories. Because the lung circulation connects the two sides of the heart, the presence of left heart diseases, which are common, puts strain on the right side. And so conditions affecting the left side of the heart are by far the major cause, making up about half of cases. For example, this might include heart valve problems or problems with a weak or stiff left side of the heart. The next commonest cause is pulmonary hypertension related to lung diseases like bronchitis or emphysema or scarring, which we call fibrosis. And even severe forms of sleep apnea, where people stop breathing for periods in their sleep, can cause it. Less common but important and treatable causes include persistent blood clots in the pulmonary arteries, often that have travelled from a deep vein thrombosis in the legs. Then there are a number of conditions that can affect the small arteries within the lungs, meaning they become narrowed due to overgrowth of tissue in the wall. And this is termed pulmonary arterial hypertension. Conditions such as congenital heart defects, blue babies, holes in the heart, abnormal pumping, that kind of thing, liver cirrhosis, and some autoimmune conditions can be complicated by pulmonary hypertension of this type. But lastly, in some people there isn't a clear cause, and we call this idiopathic pulmonary arterial hypertension. Now, since the turn of the millennium, some genetic causes have been identified, and so far about 15 genes have been implicated, although it's fair to acknowledge that a hereditary basis for pulmonary arterial hypertension was recognised as early as the 1950s.
So I know there's an awful lot of people that live with the more common type of hypertension. They take medication for it, they might change their diet, exercise or whatever, and it comes under control. Is that the kind of approach that's taken to treat pulmonary hypertension?
Well, I think the first thing to say is that pulmonary hypertension can vary between individuals, and it does depend on the underlying causes. But generally speaking, for people who develop pulmonary hypertension, unfortunately, they tend to have a bad outlook, particularly without treatment. So the standard blood pressure pills that we use for the garden variety on the arm won't have a major impact on the pulmonary circulation. Now, medications for pulmonary hypertension have developed in the last 2 decades, and these have offered a promise for patients. Yet it remains a serious and as of yet incurable condition. And these medications, however, have improved quality of life and survival, and they work by trying to reduce some of the pressure but also improving the amount of blood getting through the lungs.
So what was known about pulmonary hypertension in the early 20th century, and how was it diagnosed, Abdul?
They had available the ability to do an ECG and a chest x-ray, which had been around for at least, say, late 19th, early 20th century, but not any of the diagnostic tests that we take for granted today. So often doctors relied on the bedside examination of the heart and lungs, with just feeling the chest, listening to the heart with a stethoscope. But often by then the disease was rather advanced because the features were quite florid. And unfortunately it was invariably a death sentence, as patients would often die within a couple of years. In the middle to late 19th century and early 20th century, there were reports from a single or a handful of cases, predominantly from autopsy findings, of either an enlarged right side of the heart, often with abnormal lung arteries that were seen under the microscope. And it was assumed that these could be due to idiopathic or primary pulmonary hypertension. In the late 19th century, it was even postulated that syphilis was a cause, but this was never proven. The first meaningful pathological autopsy series was by a doctor from Birmingham. He was a cardiologist, Dr. Oscar Brenner, and he published a series of articles in 1935 following a research fellowship in America, But this never evoked any real interest, as the pulmonary circulation was so deep and inaccessible to the everyday clinicians. Now, there was a step change in the mid-1940s when cardiac catheterization was developed in the USA by Nobel laureates Andre Cunard and Dixon, and there was the ability to perform angiocardiography, which was taking a sequence of X-ray pictures after injecting contrast dye into blood vessels or heart chambers to try to identify abnormalities, and they would triangulate this information with the available diagnostic tests at the time. Now, interestingly, Sheffield radiologists adopted this quite quickly, the ability to perform angiocardiography, and were doing this at the Royal Infirmary by the late 1940s and early 50s. There were several physicians, Dr. Steiner, Goodwin, Wayne and McGregor respectively, who were performing these, and they went on to have eminent positions elsewhere in the UK following their work.
So let's take a Sheffield look. What's the Sheffield connection with pulmonary hypertension? Where do we start? Where does that story begin?
There were a trio of important characters in this story. Dr. James Brown, who'd moved up to Lincolnshire in the mid-1920s, he worked as a GP, and then over that period of time he amassed a large amount of experience looking after children with heart defects from birth, as well as rheumatic heart disease, and he became a cardiologist and a pathologist. But he was appointed to a role as a lead consultant for the regional cardiovascular centre that had been set up in Sheffield in around 1950. We'll post a picture on the website accompanying this podcast. There was another cardiologist called William Whitaker. He was a Yorkshireman, and he'd arrived from London having trained in the latest techniques of cardiac catheterization that allowed him to measure pressures within the heart and lungs and also perform angiocardiography, and so therefore he was in a position to resuscitate these services that had begun to dwindle in Sheffield. And finally there was Dr. Donald Heath. He was a recently qualified junior doctor at the time, and he had a very analytical mind and a fascination for understanding why certain conditions happened. Now, James Brown had a special interest in blue babies, that is, children born with heart defects, and because he was a cardiologist for the whole region, he was able to encounter many cases, systematically record details of them, including investigations, and what happened to them, and so therefore he gained an unrivaled clinical experience and expertise in this area. In fact, his first book was published in 1939 on congenital heart disease and was the first textbook to be available in the UK. Not only was he a great clinician, he was actually a very kind and very caring doctor, and he had dedicated to these children. There's an extract from a biography highlighting Dr. Brown's life, and when he did his ward rounds, the children would have their faces pressed against the wall to see him drive in on his Rolls Bentley, and there would be a cheer that would go across the ward when they saw Dr. Brown. On his instructions, no special preparations were made for his visits, and the wards were incredibly untidy and littered with toys. He said, "The hospitals are provided for the children, and not the children for the hospitals." He would carry out his ward round holding the hands of two small patients who had gained his honour for that day, and it was common for him to begin his assessment and examination by drawing a rabbit on the arms of his patient, a symbol to be treasured and remain unwashed. In this way, his vast clinical experience of congenital heart disease was brought to a group of happy and secure little patients. In addition to congenital heart disease, he was encountering a lot of patients with heart valve disease, particularly mitral stenosis from rheumatic fever. We now understand that children who are born with heart defects and those with valve disease can develop pulmonary hypertension, but this wasn't fully appreciated. Now, the combined skill of the trio led to a novel and methodical approach to understanding this by using the available diagnostic tests in ECG, a chest X-ray, angiocardiography, and to measure the pressures within the heart and lungs during cardiac catheterization in this newly formed regional cardiovascular centre in Sheffield. Now, here's a clip from one of the early reports by Donald Heath. "On our new unit, however, the performance of cardiac catheterization was modified. Our apparatus was Heath Robinson personified. The sister in charge of the patient would sit in one corner of the laboratory and carry on with her knitting, so that statements on such strange new terms as pulmonary vascular resistance had to be picked out from the background clicking of the needles. This clinical assessment and investigations were correlated to microscopic examination of heart and lung specimens, and these were obtained at the time of heart surgery done at a thoracotomy, or could have been obtained from a tube that was inserted down the airway to take a biopsy of lung tissue. And with this information they were able to stage the extent of disease, and they were able to start to unravel the mystery of how the lung affected the heart and vice versa. Donald remarked in 1980, "It became increasingly apparent to us that the pulmonary hypertension was exerting great influence on the clinical picture of our patients, but we were totally ignorant of the underlying pathology of the pulmonary circulation." Now, when Donald Heath started as a junior house officer in the department, his clinical duties involved looking after these patients, and they observed that many of these children would sadly die following an attempt at heart surgery because they had significant pulmonary hypertension.
Before we carry on with pulmonary circulation and the Sheffield story, was anybody working in high blood pressure of the systemic system? Well,
yes, high blood pressure in general was an area of much research in the post-war medical world. For example, a lot of work on systemic hypertension was carried out here in Sheffield by a physician called Robert Platt, who'd been born in Grindleford in the Hope Valley. He'd gone to Sheffield Medical School and he was working at the Royal Infirmary just on Penistone Road. And there was great debate about whether sort of standard common or garden and high blood pressure, which runs in families, was related to a single gene like your eye colour or to multiple genes. And this was a very important question at the time, and it continues to be an important issue. Platt proposed it was a single gene, whilst others in the field, notably Professor Pickering from Oxford, thought it was related to multiple genes. And to cut a long story short, it turns out that Platt was largely wrong and Pickering was largely right. It is mainly caused by multiple genes, but the scientific investigations and the discussions over many years in what has been termed the Platt-Pickering debate have gone down in history as a great example of how scientists have pursued the truth. And Platt later became president of the Royal College of Physicians of London, a great honour, after which he was rather grandly titled Baron Platt of Grindleford. So there was lots of work going on concerning high blood pressure, but no one was considering what was happening in the lesser circulation, as it was termed. And so Donald Heath and co-workers became travellers along a hidden river, as he poetically put it in his final paper.
So Abdul, we've got these three characters. We've got Brown, Whitaker and Heath. How did the three of them help to better understand what was going on in the pulmonary circulation?
Essentially, their main contribution was to show that pulmonary hypertension was a distinct, previously unrecognised entity with characteristic features that they could see in the arteries of those who had suffered from it. And because it could be caused by a range of conditions, they wanted to try to triangulate whether there was any relationship between how high the blood pressure was in the lungs, because they could now measure that with cardiac catheterization, and also whether there was any relationship as to what was going on within these small blood vessels. Now, Donald Heath was a medical student in Sheffield between 1946 and 1952. He was born in Henley-on-Thames and saw the war years and worked through the state system to study here in Sheffield, and he had very fond memories of his time. One thing that does stand out was that his early tuition by his schoolmaster English was to be with him for his academic life, because his writing was so clear and precise. Not for him was the loose phrase or the ill-defined concept. Now, Donald Heath worked as a house officer in cardiology around 1953 or so, and he cared for these two groups of patients. He lamented that on the left side of the ward were infants, children and young adults with congenital heart defects, or those with rheumatic valvular heart disease. Some of these were blue, and some had bedside features of severe pulmonary hypertension. And the other side of the ward were middle-aged, mostly men, who had lung disease from Sheffield's smoke, mining and steel industries. And they were later termed blue bloaters because of low oxygen levels and swelling of the legs. And they were cared for by an eminent Professor Sir Charles Stewart Harris. Interestingly, he later went on to lead a seminal study of oxygen therapy in patients with lung disease and pulmonary hypertension in 1981. Now, whilst Donald was looking after these patients, he was very curious and inquisitive. He asked his seniors What changes are present in the pulmonary circulation of these two groups of patients on either side of the ward? Is there any involvement between them? Is it the same or not? The blank look that greeted him and his questions made it clear that the medical profession was quite ignorant as to what was going on. And this stimulated him to undertake a period of research, and he obtained a fellowship from the Royal College of Physicians. His work was supported by William Whittaker and James Brown, as well as other individuals such as Mr. Judson Chesterman, who was a cardiothoracic surgeon, and utilizing precise diagnostics from cardiac catheterization allowed them to measure pressures accurately on both sides of the heart.
Will, how did they tell the world about the work that they were doing?
Donald Heath wrote his doctoral thesis on the subject of the relation of structural changes in the small pulmonary blood vessels to abnormal blood pressures in the lung, and that was awarded in 1956 by the University of Sheffield, and he happened to dedicate it to all the children with congenital heart disease and to Dr. James Brown, who devoted his life to their happiness and well-being. And the trio of Brown, Whittaker and Heath published about a dozen papers or so in the mid-1950s, and these were really the first to systematically describe the distinct changes seen in the lungs associated with pulmonary hypertension, and this included patients undergoing heart surgery and having lung biopsies, so samples of lung tissue that they then looked at, and also samples from post-mortem examinations in patients with severe pulmonary hypertension. And they really crowned their landmark work in Sheffield by summarising their findings in a particularly important paper, which was published in 1956, and it was called Hypertensive Pulmonary Vascular Disease. Now, initially they submitted it to a relatively modest sort of local British journal, the Quarterly Medical Journal, and actually William Whittaker later wrote an account of the story, and he wrote that they were spurred on by the knowledge that they'd both be soon leaving Sheffield, Donald Heath to a lectureship in pathology in Birmingham, and Whittaker to a health service appointment in Leeds. He wrote that they offered the article to the Quarterly Journal of Medicine, and as he writes, to their amazement, it was rejected. And he claims it was their first and only rejection, which is a remarkable record. But as events turned out, it was the best thing that could have happened for Donald Heath's career, because they submitted the script to Circulation, a very prominent American journal, but known throughout the world then and now. And it was immediately accepted and read by a world audience of cardiologists and pathologists. It gave Donald Heath the opportunity to show his findings to the world, and remains really one of the most important papers in the history of pulmonary hypertension.
How did this work develop after they left Sheffield?
So following his research thesis, Donald had secured a position in the Mayo Clinic in America to work with a very prestigious cardiac pathologist called Jesse Edwards. And he got that because of the publication they received in that journal Circulation, which brought them the necessary attention. Whilst out in America, Donald continued to look to study the pulmonary circulation and pathology of heart disease with Jesse Edwards, and they developed a 6th grade pathological classification for stages of pulmonary hypertension that we still use today. He returned back to Birmingham here in England to work with Peter Harris, who then became the first British Heart Foundation professor, and he continued his studies looking at the pulmonary circulation in patients with lung disease. He was then appointed as a chair of pathology in the University of Liverpool and continued working there between 1968 and 1993. However, whilst working with Peter Harris and co-workers, he did have several sojourns and expeditions to high altitude to study the pulmonary circulation. Donald recalled once, "The well-ordered life of a pathologist can be disrupted if he falls into the hands of adventurous clinicians. I was never meant by build or inclination to cavort in mountains at high altitude, but my long association with Peter Harris determined otherwise. He and Professor Inder Anand became fascinated with the problem of the responses of low oxygen levels in the pulmonary circulation in man and animals that lived in the Himalayas. There was an outbreak of pulmonary hypertension in the mid-1960s, early 70s related to use of slimming pills. It later transpired that these pills did contain some amphetamine-like derivatives, and so the World Health Organization convened the first World Symposium on Pulmonary Hypertension in 1973, in which Donald Heath led on presenting his pathological experience that he'd acquired. Donald Heath sadly passed away in 1997 at the age of 71. With regards to William Whittaker, he became a consultant cardiologist in Leeds from 1956 and was a key figure in developing cardiac services and surgery for that region, and he lived to the age of 87. James Brown sadly passed away at age 61 in 1958 following a short illness. Not many knew of it at the time, although no doubt he would have been a major driver of change had he lived longer. He was succeeded by another cardiologist, Dr. David Varell, who interestingly was one of the earliest to report familial cases of pulmonary hypertension, and also noted it was more common in females, which we recognise today. Now, unfortunately, pulmonary hypertension was and remains a serious, incurable and invariably fatal disease in those days. There were no meaningful treatments available. The median survival was around 3 years, and this was really unchanged between the 1950s and early 1980s, unless of course you were fortunate to have a lung transplant. They didn't really start till the late 1970s, early 80s. However, by the early 1990s, medications had become available, and now we've got several types of medications since the year 2000 that have hugely changed the lives of patients. However, it's still fair to say that pulmonary hypertension remains a serious and incurable disease.
Now, Will, we heard about lung transplants there. Is that something that we do in Sheffield?
We don't at the moment, but it's something that's very much part of Sheffield's history. Cardiac surgery had been pioneered in Sheffield by Mr. Chesterman at the Northern General Hospital and Mr. Fawcett at the Royal Infirmary. And their successor was really Professor Geoffrey Smith, who set up a heart and lung transplant service based at the Northern General, and that ran between 1988 and 2002. Sheffield was only one of a handful of UK centres performing heart transplants and one of even fewer carrying out lung transplants, and about 250 heart transplants were done in Sheffield, plus a smaller number of lung or heart-lung transplants. The service closed when regionally there was a push to reduce the number of transplant centres for various reasons, but many of those patients continue to be followed up at the Northern General, and the long-term outcomes from Sheffield have matched the centres who have continued to perform these complicated operations.
And how about the techniques of cardiac catheterisation brought to Sheffield by Whittaker? How was that developed?
Once introduced in Sheffield, cardiac catheterisation remained and indeed remains central to the diagnosis of cardiovascular problems, and this includes problems with the right heart like pulmonary hypertension, but also left heart disease like valve disease. But notably, cardiac catheterisation in time was also used to take X-ray pictures of the coronary arteries that supply the heart muscle with blood, and it's narrowings or blockages in these that cause angina and heart attacks. Originally, when cardiac catheterisation was introduced, it was thought that injecting dye directly into the coronary arteries would inevitably cause death, so it wasn't done. But a cardiologist called Mason Soanes in the US had one day accidentally done this, and he'd obtained actually lovely pictures of the coronary arteries, and the patient had survived, so it became an accepted technique almost overnight. And these pictures obtained by injecting dye and then taking X-rays helped diagnose problems with the coronary arteries and explain symptoms, but they also helped to plan what was a new treatment of coronary artery bypass operations. But as well as taking pictures, cardiac catheterisation was then developed further to treat narrowings of the arteries, a technique called coronary angioplasty. Initially this was done with small balloons and later with wire scaffolds or cages called stents. Coronary angioplasty was first performed in the late 1970s by Andreas Grunzig, a German-born physician practicing in Zurich. He adapted the technique from that developed to treat narrowings of the arteries of the legs, which was already becoming established. And a recurring theme was that many people thought trying it on the heart would lead to death because it temporarily interrupts the blood supply to a portion of the heart muscle, and I suppose understandably that didn't seem like a great idea. But Grunzig, with his homemade PVC balloons, got promising results. Now, enthusiasm for this technique spread quickly, in part because he was a very good publicist for it. And the first coronary angioplasties in the UK were performed in 1980. There were 3 London cardiologists who did the procedure within a matter of days or so of each other, and it's still debated as to who was actually the first. But in addition, a radiologist called David Cumberland started performing angioplasties around the same time, and that was at the Northern General in Sheffield. As part of spreading the word about coronary angioplasty, Grunzig had set up courses in Zurich, and these were massively popular. David Cumberland went on one of the first of these courses and got to know Grunzig personally. And there's a wonderful picture of the many delegates of that course, with David Cumberland sitting right by Grunzig amongst these other leading figures in the field, who all went back to their own units and seeded the technique around the world. Sheffield was therefore the first UK centre outside London to perform coronary angioplasty, and today is one of the busiest centres for the procedure in the UK. We undertake about 2,000 angioplasties each year. Furthermore, David Cumberland recognised the need to share and discuss cases, successes and failures with others to learn together as the technique found its feet, and he set up the British Coronary Angioplasty Group, which met in Sheffield hotels, most commonly the Royal Victoria, and angioplasty operators from across the country would come to these. They'd show cine films of their cases, they'd discuss their complications. And eventually this group became very established and transformed into the British Cardiovascular Intervention Society, or BCIS, which is the guiding body today for coronary angioplasty in the UK. With a bit of a rock star lifestyle, Grunzig met an untimely end in a plane crash in 1985, and actually all the three London operators from 1980 have passed away. But remarkably, Professor Cumberland is still performing angioplasties today, 45 years after his first case.
And is Sheffield an important centre for pulmonary hypertension today?
Yes, of course. So Sheffield is one of 7 nationally commissioned centres for pulmonary hypertension in England and Scotland. And the Pulmonary Vascular Disease Unit at the Royal Hampshire Hospital has grown to become one of the largest centres in Europe, particularly since several medications have become available in the last 2 decades. These require specialist care and expertise in diagnosing and treating such patients. Now, Professor Tim Higginbottom steered the Sheffield PH service in the mid-1990s, and interestingly was the first to report in 1984 the beneficial effects of an intravenous drug called prostacyclin for the treatment of pulmonary hypertension. We've also got neurobiological therapies in the pipeline coming to fruition, so the treatment of pulmonary hypertension is likely to get even more complex. We have a whole host of investigations that we perform now in the modern era, which includes many of the tests that we had before, the ECG, lung physiology, CT studies of the chest, MRI scans, cardiac catheterizations, and thankfully we don't obtain lung biopsies or perform other invasive studies apart from exceptional circumstances.
We spoke to Professor David Kiley, Clinical Director for Sheffield Pulmonary Vascular Disease Unit, to tell us a bit more about the Sheffield service.
I guess I've been able to witness some very exciting developments over the period of the last 25 years, and I think as we look forward to the next 25 years, I think there are a lot of very promising developments on the near horizon. So as a bit of a brief overview of the last 25 years, as we heard earlier from Abdul, one of the really positive developments in Sheffield was the founding of the Patients Association. So giving people living with pulmonary hypertension a voice in their care and management. And we can be very proud that Ian Armstrong, who is still works in Sheffield as a nurse consultant, was one of the founding members, with a number of different patients from across the United Kingdom at that time, and other individuals who had family members with pulmonary hypertension. And that's really been a fantastic springboard in the UK to provide patient-centred care. Now, around the same time, my predecessor in Sheffield, Tim Higginbottom, had got together with other interested colleagues in the United Kingdom and put forward a proposal to have a national network of pulmonary hypertension centres. And I think we maybe underestimate how important this has been in the development of our national PH services. It gave us a mandate to provide high quality care for people living with pulmonary hypertension. And when I look back to when I arrived in Sheffield in 2001, we had about 30 people on treatment for pulmonary hypertension. At that time, it was very expensive and delivered through very complex devices. So people would have small tubes tunneled in underneath the skin and that directly infused the drug 24 hours a day, 7 days a week 52 weeks a year. So it was a very complex therapy that many people at that time could not manage. But with the national designation and over time the development of treatments which could be taken in tablet form, there was now a therapy we had for pulmonary hypertension, increased awareness, and now in Sheffield we will evaluate over 1,000 patients a year with suspected pulmonary hypertension, and we've got over 2,500 patients under active follow-up. So it's really been very, very transformational. So along with that, we were all very young, very enthusiastic, and I worked very closely with a number of colleagues in radiology, Edwin Van Beek and also Jim Wild, and more latterly Andy Swift, to build on the strengths in Sheffield. And imaging has been a historical area of interest now going back over many years. And in fact, in 1896, the world's first pulmonary angiogram was performed on a cadaveric kidney. So an angiogram is when you inject dye into a blood vessel. And the pictures that were taken back in 1896 were very remarkable. And it was even more remarkable that the first X-ray of a hand had been performed only 6 or 8 weeks prior to that time. So imaging is really important. And as we heard from Donald Heath, histology was a very important way of trying to understand what was going on. And imaging, I think, is the way that we try and understand the workings of the human system in the modern age. And Sheffield have been pioneers in developing imaging technologies to assess people with different forms of lung and cardiac disease, but we've been real leaders in the world of pulmonary hypertension. So that was a very important development, and that collaboration with the University of Sheffield was back in 2002. So when we want to deliver good care for people living with pulmonary hypertension, particularly when you provide good care for people with a rare condition, it's important to try and be able to understand more about the underlying disease process. And Alan Laurie, back in 2004, returned to Sheffield and established a preclinical research laboratory to try and understand more about mechanisms underlying pulmonary hypertension. And over subsequent years, we've had lots of very important academic developments, and this really culminated in 2017 with the launch of Donald Heath Sheffield Research. And what we're very keen in Sheffield to do is to rebrand our research program. And we look back, and of course, Donald Heath was one of the greats of world pulmonary hypertension. And what we particularly liked about Donald Heath was his very inclusive nature to research. And at the Donald Heath launch, we were able to invite David Williams, who actually worked with Donald Heath many moons ago. And Donald Heath, when he was describing David Williams, had mentioned that David taught me that one does not need to be a medical graduate to carry out worthwhile research. Indeed, I formed the impression that his exemption from the often rigid training programs for present-day doctors allowed him a freedom for original thought. So when we were rebranding, we wanted very much an all-inclusive approach to research, recognising the very important contributions that other healthcare professionals can make. And that was a fantastic event back in 2017. I think that was really the launch pad to a very successful now modern day research program in Sheffield. And there are lots of other interesting developments, and we've established in Sheffield one of the world's largest registries where we collect information on people who've been assessed in Sheffield with suspected pulmonary hypertension. And Judith Herdman, working alongside my other colleague Robin Conliffe and other colleagues here in Sheffield, we published the very first observation of the outcomes of different forms of pulmonary hypertension, comparing outcomes of patients living with lung disease and cardiac disease and also rarer forms of pulmonary hypertension. Really, I think, very nicely following on from the work of Donald Heath back in the 1950s. So we're able to show that the form of pulmonary hypertension that you have very much defines your survival. So it was a very, very important and landmark paper. And of course, since then, we've had over 50 research studies conducted through the Aspire registry. So looking at 2025 in Sheffield, I'd say that we are in root health. I think there's lots of additional work that we need to do here. We are one of the world's largest pulmonary hypertension clinics, and we have a active, very active, what we call translational research programs. So very much from the bench all the way through to the bedside. And we've been harnessing a lot of modern technology more recently with Andy Swift really very much leading on artificial intelligence approaches, and also Alex Rothman and his team looking at new ways of monitoring patients using delivery devices. So I think if Donald Heath was alive today, I think he would be very impressed with the progress that we made in Sheffield over the period of the last 25 years, really carrying on from the fantastic foundational work that he performed with colleagues all those years ago. So I guess very finally looking at the next 25 years, so we've reflected with Abdul and Will on the 50 years of the 20th century. I've reflected on the first 25 years in this century. And I guess the question is, what is pulmonary hypertension going to look like in 25 years' time? And I'm a natural-born optimist. I think it's very likely that we're going to see a lot of progress over the period of the next 25 years. Diagnostics are very important. You can't treat a condition until you diagnose it, and I think a lot of the new technologies, artificial intelligence, which we're already using in our clinical practice, will improve the diagnosis, so we can hopefully diagnose and identify people with pulmonary hypertension earlier. The new tools that we now have as well to try and understand why people have pulmonary hypertension, what the drivers are to the pulmonary hypertension, I think will also help us to discover and implement new treatment strategies. So really this era of personalised medicine, I think, will become very important, with lots of new drug choices and trying to marry up the most effective treatment for an individual patient. So I think that will be a very important development, and we're already, with some of Alex Rothman's work here in Sheffield, personalising treatment by putting in small implantable devices, allowing us to make daily measurements and trying individuals on different drug therapies. And of course, what we all want is new therapies and new discoveries. And even over the period of the last 2 to 3 years, there have been lots of new pathways identified that are potential for targets. And I guess we all hear about prevention being the best way forward, and I think we'll understand a little bit more about the epidemiology of pulmonary hypertension. We do, for example, know that smoking now is a very important risk factor for the development of vascular damage and pulmonary hypertension later in life. So hopefully we'll understand more about what causes pulmonary hypertension and therefore prevents its development. So it's been really nice having the opportunity to talk about Sheffield and pulmonary hypertension, many of the different achievements of many colleagues, and of course, really important as always to document the history and what's happened before, because that very much helps to guide us in the future.
Will, why do you think all this started in Sheffield?
Well, I think a lot of it came from the fact that Sheffield was designated the regional cardiovascular centre in the 1950s, and James Brown and colleagues would gather patients with particularly interesting and unusual cardiovascular conditions right across the region from Nottingham and Leicester, and this enabled them to gather the information and really gain experience to have these kind of independent thoughts about conditions that previously hadn't really been considered. Sheffield is a great engineering and innovating city, and that culture and infrastructure of manufacturing and design, I think, really pushed technology in Sheffield, particularly in terms of novel ways of investigating treatments, and indeed that continues to be the case today. And there was a lot of cardiovascular disease in a big city like Sheffield, with its kind of traditional smokestack industries, large population density, great diversity of population. It really means there's a great amount of learning that can be done from the population to help the population. And then I think there was an ideal kind of meeting of minds and a melting pot of ideas between James Brown with his clinical acumen, the diagnostic tools that have been brought up from London by William Whitaker, and this interest in the fundamental mechanisms and understanding what's happening at a tissue level from Donald Heath. So I think they really did have a shared ambition to get to the truth of the matter, and this pushed them really to produce this really incredible work, which continues to be at the forefront of what Sheffield does today.
So we can listen to the experience of a patient, Julie, of her perspective of having the condition and her experience of the Sheffield Pulmonary Hypertension Service.
I started getting breathless exercising, then walking upstairs and hilly streets for 3 to 4 years. My GP gave me an inhaler, which had no effect, so I was referred to the local hospital and then on to Sheffield Hallam. In May 2012, I was diagnosed with idiopathic pulmonary hypertension, stage 3 to 4, and I immediately started oral therapies. This was the day my life changed forever. I was teaching in a high school, a lone parent, and 2 children at uni, and I was asked to give up work. I was 53. I couldn't for financial reasons, but after several blackouts, my fate was sealed, and I had to retire early on ill health. It was a catastrophic time in my life. I struggled emotionally and financially, and if it hadn't been for the excellent intervention of the Sheffield Hallam team and the BHA UK patient charity, I really don't think I'd be here today. They've protected me and my family for 13 years now, and we owe everything to them. I was put forward for a double lung transplant, but the IV therapy saved me from this to this day. My therapies, new and old, have helped my pH settle, and I'm living longer than I ever imagined, all thanks to the Sheffield team and the eternal support of the BHA UK patient charity. I live life so differently these days. I know how to pace myself, and I prepare for events and situations so that I can reduce the risk of blackouts. I have had a pacemaker fitted 4 years ago, so I feel more confident doing less but staying well. I do travel over 2 hours to Sheffield Hallam for my checkups, but if the uni wasn't there, I don't know what I'd do. They're essential to all PH patients, as they're our second family. They listen, they respond, and they fight tirelessly for us all. I have recently been asked to be a trustee for BHA UK patient charity, which I'm truly honoured to do, and I will fight for PH until the day I die. Thank you.
That's a really remarkable story. Is that kind of journey typical for a patient that's diagnosed today?
Yeah, often, sadly, many patients can have symptoms for several years before they get finally diagnosed, and many of them can have a range of investigations. And often the delay in diagnosis is because the condition can mimic other reasons for breathlessness, and sometimes, like in this case, people can be treated for asthma before the diagnosis is made.
And do patients travel such a distance to visit the Sheffield Centre?
Yeah, because of Sheffield's geographical location and catchment area, patients travel 2 to 3 hours each way to come to Sheffield. And the PHA UK did a survey a few years ago, and over 93% of participants said that they'd be willing to travel such distances to receive specialist care. And this is a testament to how services are delivered across the UK, not just here in Sheffield, but all the other centres in England and Scotland.
And well, what does the future hold? Let's broaden this if we need to, not just pulmonary hypertension, but cardiovascular disease in general. Where are we going?
That's certainly a great question, and I think the answer is there's lots of promising directions. And if we kind of focus on what Sheffield's doing, Sheffield continues to have a central place in the research of pulmonary hypertension, as well as, of course, developing new treatments, but also understanding things and looking at how patients are affected by conditions and treatments. And also researchers and clinicians in Sheffield continue to work on a wide range of solutions to a broad sweep of cardiovascular problems. For example, Sheffield's leading the way with new techniques for computer modelling of blood flow, super high resolution CT scanning of the heart, and finding better and safer drugs to treat heart attacks. We're also gaining ground in relatively new areas like digital health and artificial intelligence. And Sheffield researchers are continuing to invent new implantable devices to improve cardiovascular health. Having developed the first mitral valve replacement in the 1950s, we've now got our researchers developing and introducing systems to record continuous measurements of the blood pressure in the pulmonary circulation. And I firmly believe that Sheffield's strong track record for technological innovation will continue, and we'll see many more developments in cardiovascular medicine that have been made in Sheffield.
What a great way to end the podcast. Made in Sheffield. Thanks, Abdul Hamid, consultant cardiologist from the Sheffield Pulmonary Vascular Disease Unit and honorary senior clinical lecturer at the University of Sheffield, and to Will Parker, clinical lecturer and registrar in cardiology at the University of Sheffield. You also heard from Julie, a patient living with pulmonary arterial hypertension, and Professor David Kiley, consultant respiratory physician and clinical director for the Sheffield Pulmonary Vascular Diseases Unit. The podcast was produced by Andy Tattersall and Sheila Francis, and I'm Alan Pacey. Until next time, goodbye and thanks for listening.